Good afternoon. Uh, for the last 24 hours, I think we've been eluding on drug-eluting devices, and I think most of it, at least for me, and how I have seen this meeting, thanks to Vasomek for conceptualizing this wonderful concept and bringing this awareness and interest among us, because this has definitely been thought-provoking from whoever I've met and we've discussed over yesterday. I think it's definitely made it a little more interesting and also an understanding for all of us to know what we are doing. Having said that, I think what I'm going to talk to now and what we have been thinking about is what actually drug-eluting. I think we have spoken about trials and what is in favor, what is in not favor. I think let's look at this talk in without any prejudice, without any pre-conclusions, because what I'm going to talk about is drug elution in other arterial trees. So when we talk about this, this is not about PAD, this is not about intervening in claudicants, intervening in Rutherford 5, 6, and various other data. But I think this is a special scenario where we need to look at whether these really work. Also, whenever we come out or research comes out with anything new, it's easy to write it off. It's always difficult to accept. I think that's something which we also should learn. Medicine would not be what it is if we had always looked at everything negatively. I think whenever a new technology comes, maybe we are overusing it, we are abusing it. It's not that it is wrong. It's not that drug-eluting does not work or drug-eluting is bad. I think it's probably we are abusing it. I think with that in mind, this is what I was talking to Robbie here. I said, I'm relooking at how I'm going to start this talk, because this is what I understood and what we should be looking. So whenever technology comes, we accept it, maybe with a pinch of salt, maybe with a sack of salt, but then there is always scope for something which can be used in helping our patients get better. So having said that, I'll just go through the mundane talk of what drug-eluting stents are. As usual, most of our studies and most of our work is borrowed from our coronary cardiology work. And so is this, because a lot of times it's used first in the coronaries and then we start to extrapolate it into peripheral arterial disease. And once it works there, then we start looking at other arterial trees. So that is how these have started, and that's how this has always come up. So we do start with the studies, we do start with counter studies, we do start with how we analyze these studies. And eventually, end of the day, before we are now talking about paclitaxel with sirolimus. By the time we have a verdict, we'll have another drug. So that's how medicine goes. It's always a constant change. So drug-eluting balloons and stents offer innovative therapeutic options in managing conditions, may not be restricted to coronaries and peripheral. Like I said, we need to look at it probably, especially in scenarios like mesenteric, renal, carotids, because these are difficult areas. These are areas which are not really susceptible to reinterventions. These are areas which are critical. You cannot expect to fail here, and you want a good term patency. So these are the areas maybe these work. So this is not my verdict, but this is what I'm trying to analyze over the last 2 days with which we have been discussing. So the drugs, we all know the renal artery scenarios, the renal artery angioplasties, which are done for various reasons. But then how it started, Italy first did this in an acute renal artery occlusion. CT showed an extensive, its total occlusion in a previously stented artery. And using DEB in the management of in-stent stenosis may certainly better the superimposing another stent in a scenario like this could have been disastrous. So this is where it was used first, and it showed reasonable patency at 6 months. 6 months may not be good long enough, but then in a situation like that, he first used it and probably set the ball rolling, saying that, yes, there may be a scope for using this. Again, then came Granulli et al., talking about a bifurcation stenosis, again a single kidney, no other options, try to see how best we can help, and this is what he did. He put in 2 stents, saw that it was patent, and then let it go on. So here we don't really look at whether the patient survived, the kidney survived for 6 months, 9 months, or whatever, but then this is where it started, and this is how it, it sets the ball rolling. So then came these two studies, Takahashi and Yamamoto. Again, both spoke about angioplasties and drug balloons have shown potential in reducing antiplatelet drug use and mitigating the inflammatory response. The same thing with the second study, basically reported a case series of patients with aortitis-induced renal artery stenosis who underwent multiple renal angioplasty treatment before achieving blood flow, similar to those after 2 years of drug, balloon therapy. Of course, multiple studies have linked small renal artery diameter with increased rate of restenosis. Obviously, smaller vessels would not be so hospitable to an implant. So limitation of implants as also with the long-term antiplatelets, which have to be used in this scenario. The GREAT trial by Marcus et al. Evaluated the effect of sirolimus stent-coated compared to identical base stents. Obviously, the results were good. Again, let's not look at it as a 5-year patency or a 6-year patency, but then it set the ball rolling. So many other stents, many other trials started coming in, which did show fairly good results, especially in scenarios like this. Because if you look at a renal artery and then it's re-occluded, and then you're trying to keep it open, it's a big deal, actually. Even a 6 months re-intervention, 1-year re-intervention should not be much of an issue as long as you can keep the kidney going. Leave nothing behind has always been the concept. I think that's when we always spoke about the stents or the balloons which are there. And especially in in-stent restenosis, the main limitation involves that it may require reintervention when it comes to high restenosis rate. Prevention of in-stent stenosis in carotid, irradiated carotid arteries. Again, this is another difficult area, especially if it's been operated or irradiated. It's definitely a hostile neck, whether you want to go in and do anything, whether drug-eluting or a drug-coated balloons is going to be helpful in this scenario. Definitely, yes. I think this is somewhere where, when nothing is there, nothing is left, anything you try is always the best for the patient. So I think this is, again, a scenario where you could try, and you did achieve fair results when you started looking at the data. So a lot of cases reported, especially in carotid irradiated, post-irradiated carotid recurrent stenosis. So there are studies which quoting about 856 consecutive patients. Out of these, 9 had recurrent in-stent stenosis, despite multiple endovascular treatment within a short period of time. And these patients were treated with drug-eluting balloons, angioplasty for neointimal hyperplasia. Technical success, good, 100%. Peak velocities decreased. DEB may have a potential role in helping these patients treated, especially for in-stent carotid stenosis. Drug-coated balloon versus angioplasty in AV fistulas randomized trials, not looking very good. I think my next speaker, Dr. Praniti, is going to talk about stenting in drug elution in venous side. Whatever data I could pick up did show good results, but a little to be careful because these are bigger ones. They are delivered directly into the veins, and they tend to get washed out, especially in high-flow AV fistulas. So I'll be eager to listen to her talk to see what it has to offer to us in that scenario. Of course, like I said, in these scenarios, it has shown to be helpful in treating patients. Again, another difficult situation is the Takayasu arthritis. We all know how difficult it is. It was always a no for endovascular, for Takayasu, but then with growing endovascular, better technology, better equipment, lots of endovascular work being done. Again, very, very known for recurrence. Again, in these scenarios, it has shown that drug-eluting has worked, and it has shown good results in these situations. Again, few studies to few case reports which have been reported with fairly good patency, and then looking at it over time, if you look at a 2-year patency, it's been fairly good. So I think, again, in these scenarios, it has shown to be of help in helping these patients get better or continue to remain patent. TRAS is another scenario because we have had a good series of TRAS, but we have never used drug-eluting balloons. But again, these are obviously patients who have had transplant, single kidney, and it's very, very important to try to keep that kidney open. And in this situation, definitely drug-eluting, it has helped, or probably if it has shown better patency, I think there is a scope for using this. Mesenteric arteries, again, I don't know, not many of us do mesenteric work and isolated mesenteric work. First of all, mesenteric is a diagnosis of exclusion, and then you have to pick your lesions properly before you treat them. And getting there is technically very, very challenging for mesenteric. And once you get there, and if you have to re-intervene, it's not an easy thing. And especially if you leave behind a stent, getting back into that makes it even more worse. So if we can use, or if drug-eluting helps us in getting better patency in this scenario, it's going to be fantastic for us. So for recurrent mesenteric artery ring stenosis, again, by few of the studies to quote how they started, just to see a case of mesenteric in-stent stenosis treated, and then the results showing. Then another study, again, drug-eluting stent from the celiac trunk treated by drug-eluting stent, showing fairly good patency. I think these are the ones which set the ball rolling again for us, and then probably in 2022, European guidelines on mesenteric ischemia spoke about longer dual antiplatelet duration was introduced due to increased in-stent thrombosis associated with DS. However, questions concerning the role of DS in mesenteric arteries and optimal revascularization strategy in patients with an in-stent tumor remains unanswered. But I think as I go through the slides, I'll talk about lots of trials which we could pick up, which are ongoing. Like I said, newer drugs are it's already there, and this is a report from using Drug-eluting eluting stent in cross mesenteric ischemia. These are optical coherence tomography studies showing that good patency, 1 year follow-up has shown absence of restenosis and a good covering of neointima. These are the two trials. There are no clinical directly comparing paclitaxel to sirolimus in mesenteric artery. Obviously, I think, like I said, these are few new ones, but doesn't matter which one works, but if it helps, then it is good. So both the Sirona and the Salutonin, first of all, spoke about the safety between the two. I think that's now more or less defined. We just need to see how that safety works or how the patency remains. So like I said, there are lots of trials which are ongoing for mesenteric ischemia. There are trials which are undergoing for renal artery stenosis. Obviously, these are areas which are critical, very difficult to get ethical approvals when we do these studies. So it probably takes a little longer time. But having shown that they are non-inferior and the safety profile is good, I think we'll see more and more results coming out, and probably Vasomeg 3 or 4, we should be discussing more on this. So the key takeaways, I think DS and DCBs are transforming mesenteric and renal artery interventions. Like I said before, mind you, these are special scenarios where we are talking about, so probably they have better outcomes. So teletherapy improves outcomes and reduces restenosis. Of course, we need evidence, and evidence comes from data, and data is always interpreted the way we want. I think yesterday's talk, we said the pendulum can swing both ways, and we can make it swing the way we want. And we all know as clinician practitioners, we know how to get the patient to medical therapy, we know how to convince patient to surgical therapy or endovascular therapy. So this is also a data which we need to interpret the way we want it to, in the best interest of the patient. So end of the day, I think somebody asked, is it statistically significant or is it clinically significant? I think we all work for clinical significance. Statistical significance is only to have a medical legal covered, but I think end of the day, it's always the clinical significance we take home. Just to note the difference between these two, I think obviously stents should be used in areas which are really necessary, don't want to leave behind anything. The challenges with drug-eluting or drug-delivering drugs still remains that drug absorptions are difficult in calcified or inflamed vessels, especially in areas where we talk about Takayasu's or irradiated scenarios. Risks of long-term thrombosis due to permanent implants, and of course, flexibility of stents, especially in tortuous mesenteric arteries or right-angle celiac arteries, still remain a challenge. Of course, it does provide stent-free alternative when we talk about DEBs. DES provides mechanical support with excellent patency. Both technologies are promising, but like anything, research is needed for long-term outcomes. So thank you, and I hope that we do see much more of these in helping the patients in scenarios. Thank you.